When a patient walks into a clinic complaining of a severe headache, the standard medical instinct is to look directly at the head. We treat the cranium as the site of the disease, applying localized painkillers or muscle relaxants to force the symptom into submission. That localized approach completely misreads the biology of the pain. A headache is rarely an isolated cranial event. It is a neurological irritation, a high-decibel alarm bell ringing in the nervous system to warn of a systemic dysfunction happening elsewhere. This conceptual diagram illustrates the actual mechanism of the pain. A peripheral organ, like an inflamed stomach or a highly stressed liver, registers physical distress. It translates that distress into a neural signal, which travels up the vagus and sympathetic pathways and detonates in the cranium as a tension headache or a migraine. Swallowing a standard analgesic to treat this pain is like snipping the wires to a fire alarm while the kitchen is still burning. You temporarily silence the noise, but you leave the peripheral irritant completely intact, guaranteeing the pain will return once the medication wears off. To achieve permanent relief, the clinical objective must change. We have to stop suppressing the cranial symptom and start tracing that neural signal backward to map its exact systemic origin. By the time a chronic headache patient reaches a neurotherapist, they are usually trapped in what we call the negative zone. They have spent years consuming heavy medications without success. Their nervous system is highly sensitized, and their psychological state is deeply skeptical. Building clinical trust with these patients requires immediate, verifiable efficacy. We achieve this by deploying a strict two-pronged algorithm, a universal base protocol to stabilize the nervous system, followed by a highly specific modifier protocol to target the root cause. This foundational graphic displays the base protocol. The goal here is to immediately dial down the central nervous system's irritation. We apply 15 medulla, followed by 3 rounds of 8 medulla, and finish with 12 gas-I. This precise combination acts as a systemic reset button for irritated neural pathways. Notice these warning labels on the 12 gas-I block. There are absolute contraindications for this specific step. If the patient presents with systemic hypotension, low blood pressure, or is experiencing severe diarrhea, the 12 gas-I component must be stripped from the base formula entirely to avoid dangerous drops in vascular pressure or further bowel irritation. Once that baseline irritation is cleared, the patient transitions out of the negative zone. The nervous system is now stable enough to receive and respond to the targeted modifier blocks that will actually cure the underlying dysfunction. With the base stabilized, we begin symptom-to-system decoding. We extract specific physical triggers from the patient and translate them into systemic coordinates. We start with the most visceral biological reactions, gastrointestinal distress and vomiting. If a patient reports a severe headache that culminates in vomiting a yellow, highly bitter fluid, the biology is giving us a direct coordinate. That yellow fluid is bile. The body is forcibly ejecting it because the liver cells are irritated and producing poor quality bile that cannot be properly routed through the digestive tract. This decision tree maps the required clinical intervention. For hepatic toxicity presenting as yellow bile, the tree branches directly to our first modifier block, pan medulla paired with code equina. This combination specifically neutralizes liver toxicity, allowing the organ to produce healthy bile and instantly cutting off the cranial pain signal. But the presentation changes drastically if that vomit is laced with a green hue. Green bile indicates that the liver is breaking down excessive amounts of red blood cells, often tied to rapidly dropping hemoglobin levels. Looking at this subbranch for green vomit, the protocol must be adjusted to halt that cellular destruction. We append 6 rounds of the 1-point liver modifier to stabilize the red blood cell breakdown before proceeding. Now, consider a completely different presentation, a headache that flares intensely with minor physical movement. The patient cannot shake their head or even move their eyes side to side without triggering a spike in cranial pain. Movement-aggravated cranial pain signals high levels of internal inflammation. Physiologically, we consistently trace this specific inflammatory pattern down to severe intestinal dryness and chronic constipation. The inflamed, compacted bowel pulls the entire systemic tension network taut. Updating the tree with this new branch for movement aggravation and GI dryness, we map the exact modifiers required. We apply 2 ADR to stimulate moisture and lubricate the intestines, 4 thyroid to regulate the metabolic pace, and 6 ADR to drop the systemic inflammation. A headache is never arbitrary. Digestive outputs and physical movement triggers give us the exact coordinates of which peripheral organ is irritating the cranial nerves. Next, we map the vascular pathways. These headaches present with sudden, spiking intensity, an electric shock pattern of pain that rises rapidly, plateaus, and falls, only to spike again. This intense volatility points away from the digestive tract and directly toward blood pressure instability. The vascular system is expanding and contracting erratically, placing immense mechanical pressure on the cranial nerves. Expanding our tree to the vascular pathways, we must split the diagnosis. For an elevated systolic reading, the top number, the intervention requires 30 medella combined with cold treatment to effectively dial down the arterial pressure. Elevated diastolic pressure, however, requires extreme clinical caution. The lower number dictates the resting resistance in the blood vessels, and applying the wrong circulatory modifier here can be disastrous. Under the diastolic node, there's a strict warning: avoid the 8-pen treatment. Restricting circulation hyper-irritates the brain's vascular network. Instead, the safe protocol for diastolic spikes is 1 pen, 7 liver, and 8 chest only. Precision here is a matter of safety. Misidentifying the blood pressure type and blindly restricting circulation will exponentially increase the neural irritation. Sometimes the pain coordinates themselves are unstable. A patient might report a headache that anchors in the left hemisphere for an hour, vanishes, and then reappears entirely on the right side. This shifting, migratory pain is the hallmark of hormonal fluctuation. In female patients, this is almost exclusively tied to estrogen imbalances surrounding the menstrual cycle. The shifting chemical gradients in the bloodstream cause the vascular irritation to bounce between hemispheres. Generating a hormonal branch on our tree for shifting pain, we bypass the head entirely and target the reproductive endocrine system. The specific modifier block here is 1 right ovary followed by 1 left ovary to stabilize estrogen production. We contrast that shifting presentation with pain that refuses to move. A headache locked exclusively to the right hemisphere, or left, indicates a systemic pH imbalance. Exclusive right-sided pain means the internal environment is too alkaline. Exclusive left-sided pain means their system has tipped into acidosis. Adding a chemical imbalance branch clarifies the protocol. Right-sided pain requires the alkaline-reducing or old UDF formula to lower systemic pH. Left-sided pain requires the strict acid formula to neutralize the acidosis. Finally, we must account for external environmental triggers. Some patients only experience headaches after acute exposure to intense heat or direct sunlight, requiring treatments that rapidly cooling the central nervous system. But there is a distinct clinical edge case: a patient whose headache is triggered by cold air and physically presents with a cold head but unnaturally warm feet. This specific thermal inversion requires the application of the withdrawal formula to correct the body's internal thermostat. Even the most bizarre environmental reactions and highly localized pain patterns map perfectly to measurable internal chemical or hormonal states. This complete decision tree circuitry shows the true scope of neurotherapeutic diagnosis. Every branch, hepatic, vascular, hormonal, and chemical, roots back into the central stabilizing base formula. Let's run a clinical simulation. A patient presents with a headache triggered primarily by heat exposure, but their blood work and physical presentation reveal underlying systemic weakness and low blood pressure. Watch how the diagnostic logic processes this input. The signal travels through the base protocol, removes the 12-gas I component due to the low blood pressure, traces down the environmental branch for heat, and combines with the systemic weakness node to output the final customized modifier block. Clinical mastery does not come from memorizing a single mythical cure for a headache. It comes from fluent navigation of this entire systemic matrix. While this matrix provides a flawless logical architecture, executing it effectively on a living patient requires sharp clinical observation and absolute discipline. This work demands the level of mental endurance modeled by Swami Dayanand Saraswati, whose pursuit of foundational truth required an absolute lifelong commitment to study. Within this discipline, there is a core operating mantra: Ved padoge tho badoge. If you read the foundational texts, you will grow. You cannot shortcut the biology. Internalizing these complex diagnostic trees until they become immediate, second-nature reflexes requires the continuous, repetitive study of the source literature. Mastering neurotherapy means moving beyond simple symptom management. It is a systematic process of reading the body's hidden signals through logical deduction and the constant study of foundational principles.